Okay, good evening, everybody, and welcome to the Health and Wellbeing Board. First of all, I'd like to ask for any apologies. I know we've had apologies from John Halsall, but are there any apologies for anyone else?
So apologies from Graham Ebers, and Katie Summers will be late.
Thank you. Now, the minutes of the previous meeting, just wanted to confirm those. All those in favour, please show their hands. Thank you. Any declarations of interest from anyone tonight? No. Okay. And public question time. Do we have any public questions? No. Member question time. Do we have any member questions? No. Okay. Oh, sorry. My apologies. Jim. I'm assuming that you have no question, Jim. Please put your hand up now if you do. Okay. I think that's a no. So we'll go to Ingrid first for a COVID update, please, which is item 18 on the agenda.
Good afternoon, everyone. I'm going to share my screen just for one slide to set the scene really for our COVID update. So just this outlines the COVID rates across Berkshire and has Wokingham in here as well, obviously. So just to talk across to explain the figures here, the rate that people are used to understanding is the rate for the whole population, and that is here in this central column here. The rate for Wokingham for the week the 1st to the 7th of October is 395.6. This is on an upward trend, as it is with our several of our neighbours. This column here denotes positivity, and an important figure here because it denotes the level of illness and potential for hospital admissions is the rate over the age of 60, and pleasingly that is on its way down for Wokingham and is at around 120.6. So I think that the main message around COVID at the moment for members of the board is to understand that really at the moment residents are living two different pandemics. There is a large number of COVID cases in our school population, not unsurprisingly, given that that is our largely unvaccinated population and are obviously in close contact at school, as they ought to be, as we are trying to maintain education. So, but for another age groups, for age groups without any family members at school, for a lot of those people, it seems like the pandemic, they're living more normally, if I might say, or with less restrictions than they have at any other time over the past 18 months. So we really are beginning to see a very distinct two groups of people living through COVID at the moment. The majority of this rate here is being carried, as I say, through our primary and secondary school aged children, predominantly our secondary age group. And I just also wanted to say that some degree of this, although it's difficult to judge exactly how much, is that Wokingham, through its Children's Services Task Force, are working very closely with schools, supporting head teachers very closely, and are being very proactive in their approach to COVID cases within schools, and therefore we are carrying out more testing than some of our neighbouring authorities, and as a result of that we will be finding more cases. But in doing so, we are keeping cases at home, keeping COVID out of school, in the hope that we keep more children in school. So that's a broad, oh sorry, I'm digressing to the next item. That's a COVID update. Happy to take questions, obviously, before moving on.
Thank you, Ingrid. Any questions from the room or from Teams, please, for Ingrid? So I'll go to David Hare first, please. Thank you, Ingrid, for that. And is it an ongoing upward spiral, or is it starting to settle down? How is the numbers going? Because, you know, and as winter comes, are we expecting it to get worse? Because that would be the obvious thing, but it might, I mean, the over 60s is going down. So that's it's not quite so certain as that.
Thank you for that question, Councillor Hare. It's a good question. So, apologies, I should have said. So, at the moment, our rate is on an upward trajectory, and that remains. So, looking at the rate for a week is always a week out of date, and I can see the case numbers each day. And as looking over the last week, the case numbers continue to increase. So that will mean that for at least another week, the rate will continue to increase as well. Looking a bit further forward, in answer to your second bit of your question around going into winter, there are a few elements that might help us in the short term in terms of that rate. So the first is that we obviously have half term coming up, which will help to some degree for schools, although clearly notwithstanding the fact that families and children are able to mix outside of school as well across the half term break. We have also had the implementation of our vaccine programme in our secondary aged pupils, and that has happened across the last sort of 3 weeks, perhaps 2 to 3 weeks. That takes some time to take effect, and we would expect at 2 to 3 weeks out from that vaccination for some effect of that vaccination within school rates. So we will have to wait a little bit to see how that plays out after half term, and obviously we'll watch it very closely. But I do expect the rates certainly to go up in the very short term over the next week, yes.
Thank you, Ingrid. Question from Graham Howe.
Yeah, thank you, Ingrid. I apologise for missing much of your presentation, but I heard on the BBC that 30% of our children have been vaccinated. And what are you doing to perpetuate that number? Yeah,
thank you, Councillor Howe. So yes, we have out of our West Berkshire grouping, we have by far the highest uptake of vaccinations in 12 to 15-year-olds, approaching 30%, and that's a really, really good outcome for us. There are clearly there is an organised programme of vaccination in secondary schools, so the school immunisation teams are going around each school in turn and carrying out COVID vaccinations. There is an element of you cannot have a COVID vaccine within 4 weeks of having tested positive for COVID. So there clearly is a school age, a population that is not eligible for their vaccine at the moment. So one of the things we do need to work upon is making sure that there is a good offer for those children once they're a month out after their COVID infection. And we're working with CCG colleagues to make sure that's available locally. And we continue, as I said, through Children's Services Task Force to support head teachers and to continue to support messaging around the vaccination. I think that as the case rate grows in our secondary school pupils, that in and of itself provides some level of motivation for families to seek the vaccine for their 12 to 16-year-olds.
Thank you. Any other questions from the room or on Teams for Ingrid on COVID? That looks like silence. So thank you, Ingrid. And we'll move on to the next item, which is agenda item 19. Which is the adaptation of the adoption, I should say, of the Wokingham Health and Wellbeing Strategy into action and associated action plans. And I believe that's you again, Ingrid.
Again, sorry for the ongoing. So just as an introduction, I think many of you, if not all of you on the call, have been very much involved in the process of bringing this paper to the board this afternoon. And so I'm going to just go through real highlights of what we have already discussed in workshops and where our priorities are lying. I apologise for the vast number, lots and lots of papers attached to this item. One or two were for information, and I do just want to point out from those papers that the action plans as presented are comprehensive, but they are a dynamic document. So as they stand in that pack is not as they might stay. They are a dynamic document, and they are for just every year we will be reviewing and refreshing those action documents. So whilst the strategy is for a longer period of time, the action plans will be reviewed each year. So I just wanted to make that clear from looking at the documents. So in terms of just going through briefly where we are, so prior to COVID, if we can remember that long ago, there was work afoot to pull together a health and wellbeing strategy for Berkshire West. This has taken several years and has undergone an extensive community engagement and engagement exercise to try and understand what are the top priorities for residents across Berkshire West around health and wellbeing. Now, these are necessarily very high level, and I don't think anyone would argue with the importance of any one of them listed here. So the 5 priorities that this Berkshire West strategy has focused on and resulted in following all of that work is to reduce the differences in health between different groups of people, which is in essence health inequalities, to support individuals at high risk of bad health outcomes to live healthy lives. So that's understanding where groups of people are at a risk of bad health outcomes and to support them for in whichever the areas of risk they might be experiencing. And then new for our wellbeing board, 2 priorities around children and families, both one in the early years and one around good mental health and wellbeing for children, and the final one being good mental health and wellbeing for all adults. Now, as I say, these are clear, understandable and important priorities, but what isn't clear from this part of the work is how that relates to Wokingham, and clearly we need to make this relevant to our own population and to identify the priorities within Wokingham for us to get started on. I'll continue the work going on around each one of them. So that's what we have been doing across the summer, and many of you have been involved in that work. It has been a huge amount of work across many of the council's departments, and it's credit to all of that work that has been put in that the paper has been brought here this afternoon. So the first one is around reducing health inequalities in Wokingham, and what the data within the borough showed us that we really need to be focusing on cardiovascular disease. There is inequalities in cardiovascular disease both across socioeconomic deciles, but also between ethnicities amongst our residents that we really need to focus on and improve outcomes around cardiovascular disease. The second is around cancer. This is a new one for our wellbeing strategy into action for Wokingham, and this is because there is within Wokingham a discrepancy between men and women and the outcomes around cancer, and that is a focus for us going forward. It would be neglectful to talk about health inequalities without having COVID there as a priority. COVID has, as you all know, shone a spotlight on health inequalities and recovery from COVID, both in terms of people's own health, but also in terms of the services that may have been missed across the last year to 18 months, need to make sure that we don't exacerbate any inequalities further. So to keep that really mindful lens of health inequalities around COVID recovery. So those are the 3 priorities for Wokingham around health inequalities moving forward. For our groups that are vulnerable to bad health outcomes, we thought very hard about those groups within Wokingham, and these are the 5 groups that we will be focusing on. Our residents with learning disabilities, unpaid carers within our population, and then youth offenders, those with substance misuse issues, and those suffering domestic abuse, all of which are at higher risk of bad health outcomes. So the work within children's is being led by Children's Services, and they have led our workshops and led with the data presentation to help us understand where the priorities in these areas lie for Wokingham. And for helping children and families in early years, we will be focusing on SEND and inclusion, early intervention and prevention, and safeguarding. And for good mental health and wellbeing, we will be looking at reducing waiting times as a priority, looking at prevention and early help for children with mental health and wellbeing issues, but also making sure that we factor in across the lifespan of this strategy, COVID recovery, the impact of COVID on the mental health and wellbeing for children and young people is it's clearly significant, but the detail around that is still emerging, and the evidence around that still emerging as we go through the pandemic and into recovery. And then finally, for adults, good mental health and wellbeing, we have a very active loneliness and social isolation priority from our previous strategy, and it has been working really well. There are ways in which you can look at mental health, obviously from a sort of diagnostic point of view, looking at different ways, looking at different diagnoses, but actually loneliness and social isolation is a risk factor that underpins several mental health diagnoses, and it seems like a good focus for the local authority and partners working across the wellbeing strategy. Within that, we will obviously incorporate understanding and a focus on COVID-19 recovery. The pandemic has had significant impact on our residents with regard to social isolation and loneliness, and we're working hard to try and address that already, but that will continue in the life of this strategy. And finally, a new priority around dementia for this new Wokingham strategy into action. So what does that mean? Well, we're bringing together more partners than we have previously in our previous Wokingham strategy into action. And you will see here the groups on the left that will be taking responsibility for delivering on each one of the priorities. You'll see that listed. So this is the Children and Young People's Partnership Board. This is the Community Safety Partnership Board, and this is Wokingham's Integrated Partnership Board. Apologies for the abbreviations. Where we have cross-cutting, that means that the remit of this board is across all of those priorities. The Integrated Partnership Board will be deciding its own priorities against this Wellbeing Board in the new year. And physically active communities, I'm sure many people will know or remember, is a priority for Wokingham in our previous wellbeing strategy, and has, I think, a huge importance, and I know that members of the board share that opinion, both in terms of making healthy choices for certain vulnerable groups, but also for mental health and well-being across the life course. And I think that it's important that we maintain this group in doing its distinctive work. So those are the partnerships and action groups. At the moment, we have these three, so we will be expanding out to incorporate these boards and partnership groups reporting into the Wellbeing Board. But clearly, 9 different groups reporting regularly in the Wellbeing Board has the potential to become unwieldy. So what we are proposing for consideration by the board this afternoon is that we set up this new governance layer of a steering group to oversee Wokingham strategy into action, and that this steering group will report by exception into the Wellbeing Board on the action plans laid out to you in the papers. If the board's happy to approve this structure, what I suggest is that we bring back in November's meeting a brief item that discusses a proposed composition of that steering group. And that was the end of the presentation, but I'm happy to take questions, of course.
Thank you, Ingrid. Any questions, comments from the room or on Teams, please? Susan.
Thanks very much, Ingrid. I just wanted to ask a question about the monitoring side of things. You've obviously outlined the action plan and the groups that will deliver to that action plan, such as the Community Safety Partnership. And it's really helpful that you've just spoken about that executive group, if you like. In terms of the monitoring, can you say some more about what your expectation is of, say, the CSP or the Children and Young Persons Partnership in terms of reporting to the Health and Wellbeing Board on their progress?
Yes, sorry, thank you, Susan, for that question. So the expectation is for each one of those 9 partnership groups or action groups to report quarterly to the steering group, and we'll do that in a every other month bi-monthly meeting, whereby that quarterly can be staggered so that 5 report one time and 4 report in another. The form of that reporting, I'm hoping over a period of time will become more standardized, shall we say, but at the moment we will so the reporting will be around the outcome measures in the final column of the action plan, and we will work with partners in each one of those boards to bring it together to be a more coherent piece across for the Wellbeing Board, but at the moment it will be individual. The public health team ourselves co-chair the 3 at the bottom, so the action groups around physically active communities, social isolation and loneliness, and we will start with those groups bringing that together as a coherent reporting structure, and then work with partners to build that outwards. But the expectation is that there will be quarterly reporting against the outcomes in the final column, and that the steering group will determine the exception reporting, both in terms of good, but also in terms of risk, and that those will come to each of our wellbeing boards and be reported up to the board as a whole. I hope that's answered your question.
Yeah, that does, and I think you said about the steering group that you're going to come back to this board about the membership. Did I hear correctly on that?
Yes. So I think if the structure's approved tonight and members are happy to go with that new governance structure, then what we'll do in November at the next meeting is bring back a short item with a suggested membership for the board to shape.
Thank you.
Katie.
Sorry for being a bit slightly late, Chair. Hi, Ingrid. Thank you so much for, I came in to the very end of your presentation, and I know we've talked about that steering group, which I fully support, and feel that's the right necessary move in order to ensure that we've got effective oversight of any of the delivery plans. On the delivery plans are set up themselves, are we taking forward an approach where we're making it very smart? We know exactly what partners, what organisations we're asking to do certain actions. I know it's a 10-year delivery plan, but obviously there may be some pieces that individual partner organisations will be required to do. So we need to make sure that there's clear oversight about what the expectation is and which organisations will be taking those actions. The reasons why I'm raising this is because obviously most of the organisations will be starting into their planning years now. And so we're needing to do this quite smartly now before, from a contractual perspective, before we actually agree the individual plans that come here to the Health and Wellbeing Board. Is that being factored in at the moment, Ingrid?
Yeah, so thank you, Katie. So the action plan's laid out, I said at the beginning, but it's just to say that those are for 1 year at the moment to get us up and running. There will be work to do to shape those, but as you will see in the pack, I think it's in column 2 or 3, there is a lead partner or a lead organisation for each one of the actions, and they will be the ones that are delivering on each of those actions. So at the moment that is laid out. All partners have contributed to the writing of those action groups, so we haven't put people down without them knowing about it. So everybody has a full understanding of what they have signed up to deliver within those action plans, and that's what we will be using for year 1. And clearly there will be evolution of that both across the year, but also in terms of planning the action for year 2. I hope that's answered the question.
Thank you. Any other questions from the room or from Teams for Ingrid on this? No. Okay. Right. Well, if I can go to a vote on this, please. To all those in favour of adopting the plan. Recommendations are to approve the Berkshire West Health and Wellbeing Strategy, including the methods and outcome of the Berkshire West Health and Wellbeing Strategy public consultation, to approve Wokingham's Health and Wellbeing Strategy into action, including the priorities for focus within the borough governed by the board, to approve the proposed change to the local governance structure, see page 20 of the Wokingham Health and Wellbeing Strategy into action, to note Wokingham strategy into action plans. These plans will be dynamic and will continue to develop. They will form the basis of quarterly reporting into the strategy into action steering group. So could I ask for all those in favour to show? Thank you. That's carried. So thank you, Ingrid. I think we'll now move on to item 20 on the agenda, which is from diagnosis to end of life, the lived experiences of dementia care. And I understand we're to receive a presentation from Laura Bitchin-Anda, and my apologies if I've got that wrong, from the Alzheimer's Society. So it's all yours, Laura. Thank you.
Good evening, everyone. I'm going to try to share my screen and then I'm going to introduce myself. Sorry, it's not this presentation. Yes. Can I make sure you can see my screen?
Yes, we can see your screen. Thank you.
Yeah, so good evening, everyone. I'm Laura Vicinanza, and I'm the Public Affairs and Campaigns Officer for the South of England at Alzheimer's Society. And so first of all, let me say that I would like to thank you all for giving me the opportunity to present the findings and recommendations of our report, our Dementia Path report, which, as you can read, is From Diagnosis to the End of Life, the lived experiences of dementia care and support. So to give you a little bit of background about this report, our report analyzes the gaps between what care and support the current guidance and the legislation affords people living with dementia and what care and support people are actually receiving on the ground from diagnosis to the end of life. What this report does is to provide specific recommendations to local decision makers that can enable them to address the current care and support needs of people living with dementia. Bear in mind that this report was researched and written before COVID-19, but we do refer to the pandemic and the impact on people affected by dementia in the report. And so today I would also go through the devastating impact that COVID-19 has had on people with dementia and how the Council can support them to recover from the effects of the pandemic. So before I start presenting, I would like to say that as Alzheimer's Society, we are really delighted to see that the Council has committed alongside West Berkshire and Wokingham to prioritise people with dementia and carers in the Berkshire West Joint Health and Wellbeing Strategy, and is committed to introduce an integrated programme in partnership with other sectors for the early diagnosis, rehabilitation and support for people affected by dementia. And so I really hope that today you'll find my presentation useful, and specifically the recommendations will be useful to inform your dementia plans. So in terms of how we structure the report, we use the 4 stages of the NHS England Well Pathway as a framework. As you can see, diagnosing well, supporting well, living well and dying well. And in terms of how we gather the evidence, we use national guidance and legislation as a benchmark. We conducted a literature review of existing pathway standards and data sets. But most importantly, we have arranged a series of focus groups and interviews with people affected by dementia. And we interviewed and surveyed professionals across the country. A key theme across all stages of the pathway was a sense of disjointed and fragmented care. These meant the people were falling off the pathway after diagnosis, but then were also unable to receive appropriate post-diagnostic support, and then they struggled to access early and effective palliative and end-of-life care. So here I gathered some quotes that sort of give you a sense of this disjointed and fragmented care. We do think as an organisation that there has been significant progress in improving dementia care over the last few years, but we did find pockets of good practice happening. We included best practice example within the report, but we also think there is still a lot of work to be done. And so we have developed a series of recommendations that we think local authorities, alongside with clinical commissioning groups, can implement to better support people living with dementia and their carers. So I will now go through the different stages of the pathway and our recommendations, starting from the first stage of the pathway, which is diagnosing well. So at this stage, we identified a series of issues, one of them being that people are being misdiagnosed or opportunities to identify dementia early are being missed. We heard of many misdiagnosis stories, particularly for younger people where symptoms were attributed to stress or menopause. We've also seen that referral processes can be quite confusing, with people feeling daunted about what comes next. And then a lack of dementia data was a key theme in the report. So we saw that there is a variation between memory services and limited performance data, which can make the initiations of service improvement projects quite challenging for services and commissioners. And lastly, we've also seen that the delivery of the diagnosis, including the subtype and tailoring information to patients, is quite variable and too often focuses on what people can no longer do rather than what they can do. So to address the issues I just described, we think that each CCG should have a dedicated dementia lead who should be responsible for training, for ensuring the delivery of training to GPs on referral criteria, diagnosis, and personalized care and support planning. We also think there should be new ways of working within primary care. We know that GPs do not often have enough time to in their 10-minute GP appointments, and so we think that it's important that GPs are given enough time to appropriately assess dementia, which may include conducting an assessment of a series of appointments or conducting longer appointments. Also, we think that to facilitate dementia diagnosis, especially the complex cases of dementia, there should be formalized arrangements that enable multidisciplinary team meetings between memory service clinicians, neurology, and neuroradiology. But in addition to that, we think that's also key that memory services have clear referral pathways to enable access to different allied health professionals, psychiatrists, psychologists, occupational therapists, dementia advisor, and so on and so forth. That's because people access a diagnosis at different stages of their disease journey. And so it's important, so they will have different needs. So it's very important that they have access to allied health professionals across the pathway. And then people told us how important dementia advisors were to their care and support needs. That's why one of our key recommendations at this stage of the pathway is around the integration of dementia advisor services within memory services and within primary care. Of course, as I mentioned, I would have gone through the impacts that COVID has had on different stages of the pathway, in particular on diagnosis rates. We have seen that nationally, but also, of course, in Wokingham, there has been a steady decline in dementia diagnosis rates, which fall below the national target. So that means that many more people are living without a diagnosis of dementia and consequently without access to emotional, practical, legal, and financial support. And there are a series of reasons why dementia diagnoses have been falling. One of the reasons is because the way people interact with their GPs have changed, and that have led to a reduction of referrals from primary care from GPs to memory services. And also, as an additional challenge, we've seen indeed the memory services have reported to a significant backlog of appointments, which have led to increased waiting times. So it's from our perspective, it's really key to ensure that people can access the GP to discuss concerns about their symptoms, but it's also important that we make sure the memory services have the sufficient workforce and the resources in place to cope with the current demand. Now we'll move on to the supporting well stage of the pathway. And by supporting well, we mean the care and the support which is provided to patients within 1 year of being diagnosed with dementia. So at this stage, we found that, first of all, the information which is provided at the point of diagnosis is not often being delivered in the right way. So people told us that they either received too much information and they felt really overwhelmed, or did not receive enough information about their diagnosis, which is equally problematic. We've also found that people are struggling to access a care coordinator. So a care coordinator is something that is being recommended under NICE guidance. And what a care coordinator does basically is to help people navigate the complexity of the health and social care system to make sure that people get the right care and support. Unfortunately, we've seen that sometimes there is a lack of clarity around the role, specifically who does it and what it involves. And some professionals even told us that they didn't even know that they were someone's care coordinator. And also another issue that we find is that care planning, including advanced care planning, can be insufficient, and the specific needs of people with dementia are not taken into account. And sometimes this is made worse by the lack of integration of care and support plans. So many people with dementia told us that they didn't know that they had a care plan, or they couldn't access their own care plan. So this was quite problematic. And then for advanced care planning, we had discussions around end-of-life care provisions only occurred after a crisis. And so we've also seen that professionals felt uncomfortable about initiating these advanced care planning conversations, up to the point that sometimes advanced care planning conversation never happened. And then another issue that we found at this stage of the pathway is that the provision of post-diagnostic support intervention can be quite variable and inappropriate. So we had people aren't being offered intervention as standard, or they struggle to access this intervention. And in particular, we've seen that sometimes they are inappropriate for those that we consider hard to reach groups, such as paying communities and the LGBT community. So in terms of what we recommend could be done to address these issues, we do recommend that all people diagnosed with dementia have access to a named care coordinator, and this will ensure that people with dementia know how to contact them for consistent and proactive follow-up care and support. We want to make sure as well that post-diagnostic support intervention for people with dementia and their carers are appropriate and tailored, considering age, ethnicity, religion, gender, and sexual orientation. And then a key recommendation, as I was mentioning before, is around locating dementia advisors within memory services and primary care. This would ensure that people have the best possible chances of accessing this service and reduce instances of people falling off the pathway once a diagnosis has been delivered. And we've also heard that integrating dementia advisor services within primary care upskills primary care colleagues in dementia care and offer GPs a service to directly refer into. And then again, about advanced care planning, because sometimes there are mixed views about when advanced care planning conversations should happen, as well as who should undertake this conversation. We think there should be clear levels of responsibility at local level to avoid the sort of mentality that one person described to us as, if it's everyone's responsibility, then it's no one's responsibility. So then moving on to the living well stage of the pathway, and by living well, we mean a year after being diagnosed with the condition. We mainly found that people receive limited access to coordinated, proactive and ongoing care and support. So usually, as you can imagine, GPs are the primary clinician that coordinates the person's care. We've seen, unfortunately, that follow-up care is not the same for everyone, and many people are left to manage the condition themselves. One of the issues that we found is around care plan reviews. We found that many reviews aren't happening consistently or as regularly as required. And we've also heard the care plan reviews too often focus on physical and pharmacological needs and ignore the specific needs of people with dementia. And then we identified initiatives around hospitals and care homes, not always identifying and accommodating the specific needs of people with dementia. And as you all know, a poor integrated working and lack of appropriate care in the community, especially within care homes, can result in unnecessary hospital admissions. And then, of course, a key issue at this stage of the pathway is around the support that primary informal carers need. We've seen actually the carers are struggling to access support services for their own well-being. In particular, we've seen that carers assessments are quite variable. We've seen that many carers have not received carers assessment and they were quite dissatisfied with the quality of this assessment. But equally, we've seen a lot of issues around around respite care, in particular carers not being able to take breaks away from caring, not only because they find it challenges to book daycare and overnight care in advance, but also because respite places were not necessarily dementia appropriate, especially for those with young onset dementia. And so this means that carers were not didn't feel comfortable about leaving their loved ones in a residential place if they felt that the respite place wasn't sufficiently dementia appropriate. So a few recommendations here that could be implemented are around increasing the support for carers, around carers assessment, but also allowing, ensuring there is a straightforward methods of booking day and overnight care in advance. But also, we think that the local authority has a significant role to play in terms of providing an accessible list of recommended, an accessible list of local respite care services to ensure that carers can access the time off from their caring responsibility. And then, as you know, a lot of people with dementia spend a lot of time in care homes. Unfortunately, we know that there is a lack of clinical input within care homes, and this is often the reason that this often results in a revolving door between care homes and hospital. So we think that local multidisciplinary teams should be formed to assist local care homes. But also, I think recommendations that I've included here, but sort of spans across all the different stages of the pathway, is around making sure that all professionals that work directly with people affected by dementia are trained to the Tier 2 of the dementia training standard framework. Because we've often seen that professionals in the health and social care sectors do not really understand dementia well enough, and we think that this training will provide them with the skills and the tools that they need to deal with people with dementia and their carers. So in terms of the impact that the pandemic had on people with dementia, in addition to causing a decline in dementia diagnosis rates, what we have seen specifically is deteriorations of people's mental health and a significant cognitive decline due to restriction on social contact. And the impact has been particularly devastating for those living in care homes, because they were not able to see their carers, who were actually essential to help them maintain their cognitive skills, among other things. So we've seen people with dementia struggling. The dementia symptoms of people have started deteriorating, including memory loss, agitation, and depression. So we've seen many people with dementia losing the ability to formulate sentences, remembering words, and even feed themselves. At the same time, we've seen a decrease in the numbers of people receiving care plans or care plan reviews over the last year. So we think that in terms of recovery planning, the Council has a significant role to play in terms of bringing forward these care plan reviews as a priority in order to proactively identify the people who need cognitive rehabilitation. But at the same time, it's key that there are professionals and services in place that can meet this need for rehabilitation. And then in terms of the impact that COVID has had on carers, we know that carers have been experiencing an increasing sense of isolation and they've been unable to access respite care due to the fact that day centres had been closed and the support groups they used to rely on had been suspended. So, of course, carers were struggling even before the pandemic, so we can say that the pandemic has just exacerbated some of the issues that carers were already facing. But what I just want to say about this is that the care responsibilities of carers of people with dementia have increased, and one of the reasons why that happened is because the dementia symptoms of the loved ones have increased, and I've here put included this that carers have spent 92 million extra hours nationally caring for the loved ones with dementia, and this has had a devastating negative impact on their physical and their mental health. And lastly, I'm going to go through the last two slides, and I'm going to go through the dying well stage of the pathway. A key issue at this stage is due to the fact that people often struggle to access palliative care, including end-of-life care. We've seen that some professionals do not really recognize dementia as a terminal condition. And so these actually exacerbate poor access to palliative and end-of-life care. And then we've also seen that advanced decisions are sometimes ignored, which means that the interests of people and their wishes at the end of life are not being fulfilled. So alarmingly, we've heard from families of people with dementia who died that their advanced decisions were not taken into account and that they were provided with care which was inappropriate to what they previously wanted. So this is the last slide, is around the recommendations that can be implemented to address the issues at the dying well stage of the pathway. And we think that it's important to manage hospitalizations by integrating services, upskilling care home staff, and increasing access to out-of-hours specialist support. As I mentioned before already, we think that it's important to have some sort of clinical input within care homes, and local multidisciplinary teams that also include palliative care teams will help local care homes in this respect. And then the last recommendation is around making sure the local services are set up to ensure that professionals who are involved in end-of-life care can easily and quickly access advanced care plans. So really, thank you very much, everyone, for listening to this probably long presentation. And so, as I mentioned at the beginning of the presentation, I will be really happy to support the Council with the development of this integrated program of support for people affected by dementia, because I know it is a priority in your health and wellbeing strategy. And so I will now leave it to you if you have any questions about the reports, and I will be happy to answer them. Thank you very much.
Laura, thank you very much. Any questions or comments either on Teams or from the Council chamber? David first.
Thank you very much for that presentation. Certainly from experience of friends who've got dementia, it's often their partner who's the one who carries much of the load. And you did mention that, but also you said about someone with dementia deciding on their what's going to happen to them. So often they can't, and it's their partner who does. How do you see that interaction between the two going on, especially perhaps in the early stages, when one day the person can be very, very cognizant, and the next day they're quite scattered and their mind is not there?
Thank you. Yeah, thank you for the question. So if I understand the question correctly, are you asking, so which kind of support can be provided to carers as well? So, sorry, go on.
Yeah, I said yeah, sorry.
Yeah, so so carers need to be supported to understand how to deal with dementia. What we've seen is that carers sort of learn how to cope with the symptoms of dementia when they become carers, and I think this is a big problem, because if there were enough training as well for carers to actually they could receive, that will help them sort of care for the loved ones and feel less stressed about sort of their responsibilities. But as I said, there is an issue around respite care. We cannot expect carers to sort of not being able to take breaks away from caring. Sometimes, we've got even younger carers who also, working, so they have like day job and they're also caring for the loved one with dementia, and not having access to that sort of breaks is actually something that has been really negatively impacting on carers, and the pandemic has been sort of testimony to the issues. They were already they pre-existed COVID, but they've been exacerbated.
Yes, and certainly sometimes you say about respite care, but the carer feels guilty. They want respite care, and perhaps we can last a little bit longer and so on. But it's good for the carer to have respite care, and then they're re-energized to look after the person again and so on. And people don't realise that, and so it's very hard. Certainly, I was talking to someone yesterday who said, "Well, I can't take respite care. My husband needs me." But in fact, it'd be good for her to have some time out, and then she could come back to the task re-energized.
Yeah, if I can say, yeah, guilt is something that came out quite a lot in our report. And I think in a way, there are so many ways we can describe respite care. Something that, works for a carer doesn't necessarily work for another carer. So we need to be careful about also when we talk about respite care. Yeah, there is this element of guilt, but when you talk to carers, you can see they are conflicted because they want to stay with their loved ones, but at the same time, they want to sort of not stay with them for like a certain period of time because they need to catch up with their own stuff, really. Thank you anyway for the question. I hope I answered it.
Thank you.
I'm going to go to Matt on Teams, then to Katie, then to Debbie here. Matt,
Hi, not a question. I just wanted to thank Laura for the presentation. I thought it was really good. I thought there was an excellent list of recommendations. I know you spent some time before this meeting with Martin, who's not here today, and I'm just to sort of let the board know that we'll kind of integrate some of that work into our dementia work stream, that we've signed off today. There's a whole heap of work going on around forming a dementia alliance across the borough. And it's really just to kind of reassure the board that we'll be looking at those recommendations and kind of where we are and rolling that into our action plans and working with Laura going forward. Thank you, Laura.
Thank you.
Right, Katie.
Yeah, just to follow on from what Matt said, I think it's a very clear report that has a fantastic list of actions. I personally look at it from the point of view of healthcare, and I do take some of the points where you put down, for example, at the very beginning, which you talked about for the point of, I think it was living well, which was about not living well, it was the diagnosis. I think actually this is a point about the reset. So as a CCG, we have done a lot of work on actually doing some dedicated training to GPs in the past, but obviously we need to reaffirm that training again. Secondly, we already have multidisciplinary team meetings already in place as such. This is the way that we need to start to prioritise those as a risk stratification group so they could come forward, but integrate in any of the memory service clinicians that could be part of that. So I think this is a conversation that falls on to what Matt was talking about. We can actually add that in. On the point about the memory services and dementia advisor services, I do know the memory service does already have dementia advisors within their memory service. So we already have that in place. But I think what the issue has been, COVID for the past 19 months has prevented some of those individuals having access to those services. So what needs to happen is it's a bit of a restart. So I think we've got to take this individual report to all the partners as part of this health and wellbeing board and reignite the actual approaches that we've done before and actually refresh our dementia approach, which obviously Matt's discussed about. But obviously there are individual responsibilities for different organisations to take this forward. Can I just double check though, have you shared this actual report to Berkshire Healthcare Trust as well as the Royal Berks as well? Because obviously they are major clinicians who actually provide a lot of services to the individual dementia population as well as their carers.
So I've presented this report to the West Berkshire Health and Wellbeing Board as well as to the Reading one. And I remember presenting at the beginning of this year this report to the sort of West Berkshire Health Integration Board, which is a bit different from the Health and Wellbeing Board, but I haven't shared it myself. I'm not quite sure whether someone else from the CCG has shared it with them, but I haven't done it myself.
So I personally, I've been at every single meeting that you've discussed this at. Okay. So I personally think that there's a role for you to bring this through to those two individual trusts, because at the moment, one thing that is happening is the fact that the Royal Berks at the moment is looking at their clinical service strategy And you've got an opportunity at the moment to shape some of that conversation piece about how they, as actually major providers of healthcare services, may want to take your dementia recommendations and integrate that into their actual care services. Dementia is not necessarily well, you might take this the wrong way, but dementia is almost like anybody could get dementia, but they're also integrated into lots of different other services. So some people might have diabetes or cardiac disease. So you would like to think that any person that was entering into an outpatient department or an ED department is also being aware that that person has dementia and how they need to flex their actual clinical service delivery as part of that recommendation. So as an action from this chair, I will actually make sure that actually she is, we get some work where actually she brings it into the Royal Berks and Berkshire Healthcare Trust to present this.
Thank you, Katie. Right, to Debbie now.
Yeah, I was just going to build on what Katie has been saying, really. So there's already been a lot of work done, you know, in the Royal Berks. And again, it's these things that need to be refreshed because you're always, you know, putting different extra things in. But, you know, they had, you know, dementia aware kind of, you know, superstars, getting everybody signed up to don't think dementia and do think dementia. There are also the booklets about this is about me, so understanding, you know, about the person. The MDTs Katie has talked about. And again, you know, when you're thinking about nursing homes, we have an amazing service through BHFT, where there's one of the community geriatricians who support our rapid response and treatment teams who work very closely with our nursing homes. And within that, they have a psychologist that goes around as well. So they are very well versed in dementia and end-of-life care. And again, our MDTs in primary care, you know, we're not just bringing a person that we are concerned about. We usually discuss their relative as well in those MDTs. So we're trying to do as much as possible to support these people. I think the other avenue who I always post people to are our voluntary services who have got so much knowledge about, you know, the legalities and the rights and where to access things. So when we're thinking about joined up care, it's actually everywhere. As Katie said, anybody and everybody can have dementia. It is a really difficult condition because the person who's got dementia, as Dave was alluding to, can go in and out of lucidity, you know, can be very angry with the diagnosis when they're quite lucid. Other times is kind of totally aware of what's going on at all. And, you know, for the carer, it's like having a 2-year-old, no disrespect, that's more cunning at the age of 78 or 80. So there is a lot of sense. And I think for the older age groups, again, as David has said, there is so much guilt because they married for better and worse, and they cannot leave them for 1 second. They don't want to be a burden on their children, so they feel as though they have to shoulder all the time. And as GPs, to be honest, when I'm talking to someone who's got dementia and saying, have you thought about the future? It's about 4 or 5 years with me starting that conversation before someone in that family says, actually enough's enough and I have to consider that. That's usually when there's a slight crisis, and then trying to get things organised is really difficult. So it's a really big subject. There's lots of those things that you recommended. I think we are already doing. We can always do it better.
Thank you. Any other questions or comments, either in the room or on Teams? No, well, I'll conclude by thanking you, Laura. I think your reports had obviously a very receptive audience, and it seems like our colleagues in healthcare, if you were or one of your colleagues would be prepared to talk to them on a wider basis, that could have real benefit. So thank you very much.
Yeah, thank you very much. And I will be happy to work with all of you. Thank you.
Thank you. Okay, so now we're moving on to item 21, which is the ICP, United Executive Chairs Report. There's obviously an update in the pack on discussions and developments from the ICP executive meeting. I don't know if anyone wants to talk to this. Basically, more than happy if Matt wants to talk to it. Thank you, Matt.
Yes. So I think this was for me and Katie to talk to, but if it's all right with Katie, shall I go first and then you can kind of chip in? I suppose the idea behind this report, and it's got a bit scuppered because this report was produced and we've rolled on the agenda a little bit, is to try and keep the board up to date with what happens at the Integrated Care Partnership board, so that there's a kind of read across and between the two boards. And for those that don't know, the Integrated Care Partnership Board is the kind of Berkshire West board that all health and social care partners get together to look at how we better coordinate and integrate services across the patch. So I was thinking maybe what we want to do is keep these papers coming so that there's a good sense of what's going on between the boards. But maybe it might be worth doing a bit of an overview at the next board, so this board kind of gets a bit of an overview about how that works and some of the priorities. So we'll do that sort of next time. I don't know if anyone's got any questions about what's in the paper. Certainly the key priorities there are around rapid community discharge and pressure on primary care. But actually some of the debates moved on since that report because it's a few months old now because we rolled over the agenda. So it's just to introduce that. Katie, did you want to say anything else?
No, I don't think so. I think it's quite hard to just make people aware. Unfortunately, this is a month out of date because the UE met this morning. So it's a bit of a difficult challenge. And I agree with Matt. I do think there needs to be a bit of a wider conversation. I think generally that there is a lot of quite meaty discussion items that are currently going on in the actual Berkshire West Integrated Care Partnership, and I would actually think that it might be worth us doing it as a sort of a workshop to get you up to speed about some of those discussions and have your contribution into what's being talked about now as a Berkshire West being it sounds like a terrible phrase, but a place-based partnership. Sounds terrible, but I think that's what I'd recommend, Chair, if that's okay.
I'd be more than happy for that to come forward. More than happy. I believe Meriden would like to say something as well. Meriden, over to you.
Sure. We've had some discussions around the health and wellbeing strategy across Berkshire West and the Wokingham action plan, which I have to say is excellent. So we've had some discussions around how the governance is going to work between the ICP and Wokingham. So it might be good to revisit that just to make sure that the ICP approach to the health and wellbeing strategy is actually led by Wokingham and the other councils and the health and wellbeing boards. So I think maybe any future reports would be good to pick up on that.
Thank you. Any other questions or comments on this? No? Okay. So we now move on to the forward programme, which is in your packs. Next meeting on the 11th of November, one after on the 9th of December. If anyone's got any comments or points on that. No? Okay, great. Well, I think that concludes the meeting, unless anybody's got any other business they want to raise. No? Well, I'll say thank you very much to everyone and then good evening.